Hi students, I'm Dr. Gayathri and today we are going to discuss about newborn disorders. Now the normal period of pregnancy, or in other words you call the period of pregnancy is called period of gestation. So the normal period of gestation or the normal period of pregnancy in human beings is 37 to 42 weeks. So in words, if we tell in days, if we tell that will be 280 plus minus 7 days. So if the babies are delivered or if the babies are born between 37 to 42 weeks of gestation, we call them term babies. If the babies are delivered before completion of 36 weeks, the babies are called preterm babies. Now these are the features of a normal newborn. So we call it a normal newborn baby if the baby is delivered between 37 completed weeks and 42 weeks. So on an average, a newborn healthy baby will weigh 2,500 grams or 2.5 kilograms, and soon after the delivery the baby will cry. So with the first cry of the baby's normal respiration is established, and once the baby's umbilical cord is clamped and cut in the middle and the baby is separated from the mother, a normal newborn baby is able to adapt according to the environment as a separate individual. So that's a normal newborn baby delivered between 37 to 42 weeks of pregnancy. Now when a baby is born, we have to provide care for the baby. So this is called postnatal care. So the care during pregnancy is called antenatal care. So antenatal care is provided to the mother. Then the delivery procedure is called parturition, and therefore care of the mother during delivery is called intrapartum care. So after the child is born, the care given to the baby is called postnatal care. So these are the things that should be considered when you take care of a newborn baby. So the baby has to be kept clean. There has to be, if napkins are used, then the napkins have to be clean. They have to be properly washed, and frequently the napkins have to be changed, or else the baby can develop napkin rashes and other infections. Then if diapers are used, time to time the diapers have to be changed and the area has to be properly cleaned and kept dry. So that's cleanliness. Then when it comes to feeding of the baby after delivery, for the first 6 months the baby has to be fed only with breast milk. So the baby should not be given not even a single drop of water, should not be given even water. So it has to be only breastfeeding up to 6 months. So this is called exclusive breastfeeding. The next important thing in when taking care of a newborn is vaccination. So there is, in Sri Lanka, there is an expanded program on immunization. So according to this EPI schedule, there are certain vaccines which have to be given at specific months after birth. So these vaccines need to be given. So usually in case of hospital deliveries, before the mother and the baby are discharged from the hospital, within 24 hours after birth, the BCG vaccine is given, and thereafter once the baby is taken home, the parents have to take care to give all the vaccinations duly according to the EPI schedule, which is mentioned in the CHDR, Childhood Health and Development Record. So compared to normal babies who are delivered at term, the preterm babies, that is the babies who are delivered before completion of 36 weeks, these babies, they have got much complications. So here are some complications. Now here are some features of these preterm babies. So they are characteristically inactive compared to a normal newborn baby. Extended posture. They have feeble cries. They have irregular respiration. That's because they have breathing difficulties. Translucent skin with less subcutaneous fatty tissues. They have thick vernix caseosa. So vernix caseosa is the white color cheesy-like substance which you see on the skin surface when the child is being born. So a preterm baby will have more of this thick vernix caseosa. Then they have few skin creases. The skin creases are not properly developed as in a normal newborn baby. Then they have prominent lanugo hair, and they have poor breast development and soft nails, or the nails maybe they are not properly developed up to the fingertips. And they have immature external genitalia. So these are some features of preterm babies. So you can see the preterm babies, they have got physical characteristics compared to a normal newborn baby, and also they are prone to develop a lot of complications, a variety of physiological handicaps because of this prematurity, because ideally by this time they should be growing inside the mother's uterus, because there's still time for the organs to develop before the child is born. But due to some reason the baby is delivered before term, so that is why the baby is having a lot of physiological handicaps. So here are some of the physiological handicaps a preterm baby might have. So they can have temperature instability. They will be unable to control their body temperature. As a result, they can become hypothermic. They have respiratory difficulties. Then their body organs are not properly matured, especially their liver is immature. Therefore, they can face complications. Then they can have a lot of gastrointestinal and nutritional problems. Renal immaturity. So first of all, we'll see temperature instability. What do you mean by temperature instability? That is, the newborn babies who are delivered before term, they have got, now all the newborn babies, they have got a larger surface area compared to adults. Children have a larger surface area compared to adults, and as a result they easily, the body heat can be lost across this large surface area, so the babies can become hypothermic very easily. So this can happen in any newborn baby. But in addition to this condition, in premature babies, they have got less subcutaneous fatty tissues. Their fats are not properly developed, and also they have got a more translucent permeable skin, and they have got an even larger surface area, so that in preterm babies the chance of losing heat is more compared to a normal newborn baby. So therefore the preterm babies are more prone to develop hypothermia. So this condition can be overcome by several measures. So one thing is skin to skin care. That is, you keep the baby closer to the mother's breast, so that when the baby's skin comes in contact with the mother's skin, the warmth of the mother's skin will be transmitted to the baby, and this will help to keep the baby warm. So that is one thing. This is called kangaroo care or skin to skin care. The next thing you can do is you can properly wrap the baby with proper clothing in order to ensure less heat loss. So nowadays there are other techniques that are being used, like cellophane, wrapping up with cellophane to preserve heat, to preserve heat or to prevent hypothermia in newborn babies. Next we'll see respiratory difficulties. So there are some respiratory conditions that can occur in a preterm baby. So one condition is respiratory distress syndrome. So respiratory distress syndrome is also known as hyaline membrane disease. Another complication is Meconium aspiration syndrome. Now, the preterm babies are at risk of developing aspiration pneumonia because they have poorly developed cough reflex and gag reflex. Then they are unable to control their sucking and swallowing. So therefore, when they are being fed, there is a chance of this milk entering into the respiratory passage due to this poor coordination between sucking and swallowing. Then they have got their ventilation is not very efficient. So this is due to weakness of the respiratory muscles as well as due to pliable thorax, the weakly formed thorax. Next, the newborn babies, their respiratory center, which is located in the medulla oblongata of the brain, is not properly matured, and as a result, in these babies the respiration is not properly controlled. So this can result in respiratory transient loss of respiration, which is called periodic breathing or sleep or apnea, right? So there will be cessation of respiration at times. So this is what we call apnea. So that's due to immaturity of the respiratory center in the brain. So first we'll see respiratory distress syndrome or the hyaline membrane disease. So it's a condition which is mostly seen in premature babies. The problem is, now in our lungs, in newborn babies as well as in adults, now you have to keep in mind that after the child is being born, and with the first cry, when the baby's normal respiration is established, thereafter the baby's respiration is similar to an adult. So in human beings, in after birth, the lungs, we know the lungs expand during inspiration to allow air to flow into the lungs, and during expiration the lungs will reduce its volume back to its normal level. But you have to remember, our lungs have a tendency to collapse. So rather than going into its normal position, the lungs tend to collapse more. They tend to shrink during expiration. But in a normal person, this collapse of lungs during expiration is prevented by a lipid that lines the lung surface. So this lipid is called surfactant. So surfactant in a fetus is formed during 32 to 34 weeks of pregnancy. Therefore, if a baby is delivered before 32 weeks, then what happens is the baby's surfactant is not developed. Therefore, there is no surfactant to line the lung tissues, the inner lining of the lungs. So when this baby is delivered and when he tries to breathe in air and exhale air during expiration, what happens is the lungs will collapse. So this condition is what you call the respiratory distress syndrome or hyaline membrane disease. So if you look at this picture, you will see now in a normal person, this is what happens. There is surfactant lining these alveoli so that during expiration the lungs will not collapse because they have got this surfactant. But in a baby with respiratory distress syndrome who has less or no surfactant production, what happens is there is no surfactant lining these alveoli walls, and therefore during expiration these lungs, they collapse. So when the lungs collapse, respiration will not take place properly. So the amount of oxygen taken into the body is low. So the body needs oxygen for its functioning. So that is why respiratory distress syndrome is dangerous. So this is that. Surfactant is produced between 32 to 34 weeks of pregnancy. Therefore, if the babies are delivered before 32 weeks of pregnancy due to lack of surfactant, when they are delivered and when the babies try to breathe, their lungs will try to collapse. So this condition is what we call respiratory distress syndrome or hyaline membrane disease. So if now sometimes we may want to take the baby's preterm because of some medical condition in the mother or in the fetus, or due to some obstetric complication in the mother, due to which pregnancy cannot be continued further because it's dangerous either to the mother or to the baby. So in that case, it's an anticipated preterm delivery. That is, we know that we have to deliver the baby preterm. So if in those conditions, there is one thing we can do to prevent respiratory distress syndrome. That is, we can give dexamethasone injection to the mother. Now dexamethasone is a steroid. It's a cortisol. It's cortisol. So if you give it to the mother, this cortisol that enters into the mother's blood through the placenta will go to the baby, and in the baby's lungs it will stimulate production of surfactant. So then if you give this injection a couple of days before, then at least some amount of surfactant will be produced in the baby's lungs by the time the baby is delivered. So that is one way how you can prevent respiratory distress syndrome in newborns, and that is in anticipated preterm deliveries. Now we'll see the treatment. Now what will happen? How can we manage a baby that is born with respiratory distress syndrome? So the problem is the baby does not have enough surfactant in his lungs. So the treatment is to give surfactant from outside. So this is called surfactant replacement therapy. Apart from that, the baby is having problems with oxygenation. So at the same time, we have to give oxygen. And this may be given in the form of CPAP, that is continuous positive airway pressure. So this is how you give surfactant. So the method is called INSURE technique. So INSURE, IN stands for intubation. Then SUR stands for surfactant administration. And then E stands for extubation. So these are the steps in giving surfactant from outside through the endotracheal tube. So this is the endotracheal tube applied orally to administer surfactant into the baby. Right? At the same time, you have to give oxygen and maintain nasal continuous positive airway pressure ventilation. So now there are some complications of respiratory distress syndrome. Now in respiratory distress syndrome, what happens is the lungs tend to collapse during expiration. So then your respiration, the whole respiratory function becomes inefficient. So here are the complications that can occur as a result. So the alveolar can rupture. So when the alveolar ruptures, alveolar contain air. So when they rupture, this air will enter into the pleural space. So this can cause pneumothorax. When this air loses into the mediastinum, it can cause pneumomediastinum. When this air loses into the tissue spaces, it can cause interstitial emphysema. Intrapulmonary hemorrhages. That is when the babies are on surfactant therapy, sometimes there is a chance of damage to the blood vessels in the lungs causing hemorrhage. So this is called intrapulmonary hemorrhage. Then intracranial hemorrhage. So intracranial hemorrhage is mostly seen in babies on CPAP, mechanical ventilation, when they are given mechanical ventilation in order to facilitate their breathing. So these are some complications of respiratory distress syndrome. And the next thing is delayed mental development. That's because now in RDS there is inefficient respiration. So the amount of oxygen taken into your body is less. As a result, the amount of oxygen that goes to your different organs are also less. So similarly, your brain will not receive a good oxygen supply. So we know the brain tissues, they need to have a proper oxygen flow if it is to function properly. So when the brain does not receive a proper oxygen flow, then your brain functions will not take place properly. So this can lead to delayed mental development. Now we'll see another condition that can occur in a preterm baby, and that is called Meconium aspiration syndrome. So this is what happens. Now in a normal baby, now we know inside the mother's uterus, the baby is inside a water bag. So that is called amniotic cavity. The fluid that is there inside this water bag, that is the amniotic fluid. So this amniotic fluid is made up of the baby's urine, and this is clear. It does not contain meconium. Meconium is the stool of the baby. So in a normal baby, this amniotic fluid is clear. It's clearly the baby's urine, and it does not contain any of the baby's stools or feces. But when the baby is in distress, what happens is, distress is when the baby does not get a proper oxygen supply from the mother through the placenta. What happens is the baby's anal sphincters relax, and as a result the baby will pass meconium or stools into the amniotic fluid. So this is all stools, the baby's stools in the amniotic fluid. So then these stools that are there in the amniotic fluid can enter through the baby's mouth and nose. So when they enter through the baby's mouth and nose, we know now pharynx is a common passage for respiratory tract and the digestive tract. So when this meconium enters through the nose or through the mouth, what happens is at the end they will go to the lungs. They'll pass through the airways and will enter into the lungs. So when a foreign body enters into the lungs, it is dangerous. So that is the problem with meconium aspiration syndrome. When a foreign body enters into the lungs, the condition is called aspiration. So here there is aspiration in the lungs. And what is the thing that is aspirated? That is the baby's own meconium. So that is why the condition is called meconium aspiration syndrome. So remember, meconium aspiration syndrome occurs only when the baby is in distress. So the baby is in distress mostly when the baby does not get a proper oxygen flow across the placenta. Now this is what happens. See, you can see through the nose or through the mouth, the meconium will enter through the pharynx. It will enter into the trachea, from there into the right and left bronchi, and from there it will enter into the lungs. So meconium in lungs, aspiration in the lungs. So that is why it's called meconium aspiration syndrome. So if you take a chest x-ray of the baby, this is how the meconium aspiration would look like on the chest. So you can see apart from the air shadow, you can see some solid structures in the lungs. So that is meconium. Now these are the things, these are the conditions where the baby can go into fetal distress and can pass meconium and resulting in meconium aspiration syndrome. So the main cause is placental insufficiency. So this could be due to when the mother's blood pressure is increased. So this condition is called where it could be a blood BP rise in the mother, or sometimes BP rise in the mother associated with other complications. This condition is called preeclampsia. Then it could be due to oligohydroamnios, that is when the amount of amniotic fluid is low. The condition is called oligohydroamnios. So that's another cause for fetal distress. Then it could be due to certain drugs taken by the mother, especially substances like cocaine and tobacco. Then it could be due to infections in the mother, that is chorioamnionitis, infection in the mother. Then it could be as most of the time, all these conditions or any other condition that results in low oxygen supply to the baby can make the baby go into fetal distress, as a result of which the baby will be passing stools or meconium. So then when these stools enter through the baby's nose or through the mouth, they can go to the lungs and cause meconium aspiration syndrome. So this is what happens in meconium aspiration. So when the meconium is inside the airways, it blocks the air from entering into the lungs. So it results in hypoxemia, lack of oxygen in lungs, as a result lack of oxygen in blood. Then now this meconium, it can cause inflammation. Now it's a foreign body, so it can mediate inflammation in your lungs. So this is also dangerous. The other thing is meconium causes inactivation of surfactant. So then the lungs probably tend to collapse. So both these conditions, inflammation and inactivation of surfactant, can cause the lungs to collapse. So this is called atelectasis. So when the lungs collapse, the blood flow inside the lungs will be altered. So then oxygenation will not take place properly. So this results in low oxygen in blood. And at the same time, inside the lungs, there will be increase in the pressure inside the lungs. So this is called pulmonary hypertension. So this is what happens when there is meconium aspiration in the fetus. So this is the management of meconium aspiration. So there will be you will have to give respiratory support using mechanical ventilation. Then you'll have to maintain a proper temperature in order to prevent hypothermia. You'll have to give surfactant, and at the same time meconium aspiration can give rise to pneumonia. So to treat that, you'll have to give antibiotics. In very severe cases of meconium aspiration, sometimes extracorporeal membrane oxygenation may be needed now. So that's a complicated procedure in severe cases of meconium aspiration syndrome. So these are the nursing interventions that are required in meconium aspiration syndrome. So during labor, when the child is being delivered, you have to be cautious about signs and symptoms of respiratory distress. So you will see the baby is not breathing properly. Once the umbilical cord is clamped and cut, the baby will not breathe. Maybe the baby will be bluish in color. You will see meconium staining. You may see the respiratory tract is obstructed with meconium. So in that case, you will have to do an endotracheal suctioning in order to help the baby to breathe normally. And then you have to closely monitor the baby's respiratory lung sounds, the respiratory sounds or the lung sounds, breath sounds, using stethoscope, and frequently assess the baby's vital signs: pulse, blood pressure, temperature, and respiratory rate. And then you'll have to give oxygen, ventilatory support if needed, probably mechanical ventilation. And when you give oxygen, you have to make sure that it is properly humidified and warmed to match the body temperature. You have to maintain a proper thermal environment for the baby to prevent hypothermia. And you have to also educate the family about what this condition is and what type of management is required. Now here are the complications of meconium aspiration syndrome. So when a foreign body, the meconium, enters into the lungs, it can induce pneumonia. So that is called aspiration pneumonia. When the meconium blocks the airways, it causes breathing difficulty. When there's meconium inside the lungs, the alveoli can rupture, so air can enter into the pleural space, causing pneumothorax. Then the babies can develop persistently high pressure inside the lungs. So this is called persistent pulmonary hypertension. And since the amount of oxygen that enters into the blood is low due to poor oxygenation, the amount of oxygen that reaches the brain will also be low, and this can induce brain damage. Right. So next we'll see some complications that can occur in the newborn baby due to immaturity of the liver. So when the liver is immature, what happens is, now in a newborn baby, the red cell count, the red blood cell count is very high. So when these red blood cells break down, they form bilirubin. So this bilirubin is further metabolized in the liver. So in a preterm baby, since their liver is immature, this bilirubin is not properly metabolized by the liver. So this results in increased amount of bilirubin in blood. So when there's increased amount of bilirubin in blood, this causes the baby's white portion of the eye, that is the sclera, to be yellow in color, and also the skin gets a yellow discoloration. So this condition is called neonatal jaundice or neonatal hyperbilirubinemia. So this neonatal jaundice or neonatal hyperbilirubinemia therefore results from immaturity of the liver. So this is what happens. When your red cells are broken down, they are broken into heme and globin. So globin is the protein. So it will enter into the protein pool and help in protein synthesis. Heme consists of iron and biliverdin. So iron will be stored, and it will be part of this iron will be stored in the liver, and part of this iron will be used for new hemoglobin synthesis. Now from this biliverdin, bilirubin is produced. So this bilirubin goes to the liver, and in the liver this bilirubin is conjugated further and is formed into a substance that can be excreted in urine, right? So it's formed into a water soluble substance called stercobilinogen, stercobilin. So this stercobilin will go to the kidneys, and there it forms the urobilinogen, which is excreted in urine. So that is why in a normal person this bilirubin does not get accumulated in blood. But when the liver is immature in a newborn baby, what happens is this unconjugated bilirubin that is produced from biliverdin cannot be further conjugated in the liver, and therefore this bilirubin, this unconjugated bilirubin, which is water insoluble, cannot be excreted in urine. As a result, it gets accumulated in blood. So when this bilirubin level is increased in blood, it causes yellowishness of the eye and also the skin. So that is what we call jaundice. So jaundice in a newborn is of two types. So it could be physiological jaundice or it could be pathological jaundice. Now physiological jaundice is now I have told you, in a newborn baby the red cell count is high, and therefore in all newborn babies the liver is somewhat unable to handle this high load of biliverdin that is produced by breakdown of these red cells, and therefore all the newborn babies can develop some amount of jaundice after birth. So this is called physiological neonatal jaundice. But you have to remember, this physiological neonatal jaundice usually appears after 24 hours of birth. That is, it never appears within the first 24 hours of birth. It always appears after 24 hours, and the bilirubin concentration in blood is not that high, so it will be less than 5 milligrams per deciliter, and it will stay for about 2-3 days, and then it will go off. So most of the time it disappears without any treatment, or sometimes we recommend the mothers to expose the baby to early morning sunlight around 6:30 to 7 o'clock in the morning, and with that treatment, with natural exposure to sunlight, the condition usually subsides in 3 to 4 days time. So that's the normal physiological jaundice. It is never prolonged more than say to the maximum it will stay for less than 5 or 6 days, and it's never prolonged more than 2 weeks. But there's another form of jaundice that can occur in a newborn baby which is not normal. So this is called pathological jaundice. So in pathological jaundice, the feature is the baby develops jaundice within the first 24 hours after birth, and also the baby's bilirubin level, if you check the blood for bilirubin, you will see the bilirubin level continuously keeps on increasing, and the jaundice usually lasts for a longer period. Most of the time it lasts for more than 14 days, and this pathological type of jaundice will never subside on its own. So always you have to treat the condition according to cause. So that's the difference between physiological jaundice and pathological jaundice. So physiological jaundice is the type of jaundice which you can see in all the newborn babies, which is normal, appears after 24 hours, lasts for about 2-3 days, and then goes off, never lasts for more than 14 days. So it usually is self-resolving. You need not treat the condition, it subsides on its own. But pathological jaundice is when the jaundice appears within the first 24 hours after birth and lasts for a long time, for more than 2 weeks. So this is very dangerous because the blood bilirubin level keeps on increasing, and the condition does not subside on its own. So it has to be always treated. So here are some causes. Now for pathological jaundice, here are the causes. Now if it develops within the first 24 hours, it is mostly due to an incompatibility of ABO or RH blood groups between the mother and the baby. So this occurs most of the time in RH positive babies born to RH negative mothers. So ARH or ABO incompatibility. So this is the most common cause of severe pathological jaundice in newborns within the first 24 hours. Apart from that, infections like GBS infection, that is Lancefield group A beta hemolytic streptococcal infection, as well as other congenital infections like toxoplasmosis, rubella, cytomegaloviral infection, herpes simplex viral infection. So all these infections in the baby or RH or ABO incompatibility is the commonest cause for this pathological jaundice that appears within the first 24 hours. Apart from that, there are lots of other causes for pathological jaundice. So it may be due to some abnormality in the enzymes that are required for this conjugation process in the liver. It could be due to breast milk jaundice. Now there's a compound in breast milk that will impair your conjugation process. So this is called breast milk jaundice. So in some people this can occur, or it could be due to severe dehydration in the baby, right? So it could be due to neonatal hepatitis. When the baby's liver is inflamed, the liver will not be able to conjugate the bilirubins properly. So it could be due to some obstruction in the bile pathway, so that these conjugated bilirubins are not properly excreted. So all these are different causes for pathological jaundice. So what you have to remember about pathological jaundice is it's always abnormal. It's not a normal condition, and it does not resolve on its own. So you have to treat the condition always. So this is how neonatal jaundice is diagnosed. One thing is clinical features. That is, by examining the baby, you will see the baby's skin. Here you can see the baby's skin has become yellow, and also if you examine the white portion of the baby's eye, you will see it's yellow in color. So this is called jaundice, right? So this yellow discoloration due to increased bilirubin is called jaundice. So that's based on clinical features. Next, you can do a complete blood count. You can check the baby's hemoglobin, which is part of your complete blood count. Then you have to check for the baby's blood group and RH factor, and check that with the mother's blood group and RH factor to see whether there is any incompatibility between mothers and babies ABO and RH factors. Then you have to check for signs of torch infections. Now VDRL is a test which you do to diagnose syphilis. So sometimes when the mother had syphilis, it could have transmitted to the baby across the placenta, causing congenital syphilis in the baby, and this infection could be the reason for jaundice. So these have to be checked. Then another important test is thyroid function test, TSH. That is because thyroid hormone deficiency can also give rise to this yellow discoloration, but it's not jaundice. So, and also it is important that you do this test, because if it is due to low TSH, then the child is going to develop mental retardation. So this mental retardation can be prevented by starting thyroxine immediately. So to make sure that it is jaundice due to liver immaturity and not due to thyroid abnormality, you have to do the thyroid function test, TSH. Next, you have to do liver function tests to see how the baby's liver is working. And also, you have to keep checking the blood bilirubin level, because in pathological jaundice, the bilirubin levels will be increasing. It keeps on increasing, so it's dangerous. So when the baby is on treatment, you have to keep checking the bilirubin level to make sure that the baby's condition is improving and it's not rising further. The bilirubin counts are not rising further. So this is the management of jaundice. Now in physiological jaundice, you have to continue breastfeeding, maintain the baby, you have to keep the baby clean and in a proper temperature to prevent hypothermia. So and you have to ask the mother to be cautious about the yellow coloration of the baby's skin and eyes. If it continues for a long time, then she'll have to seek medical advice. Otherwise, it will resolve on its own. But sometimes we also recommend exposure of the babies to sunlight. So that is, we recommend the mothers to take the baby to early morning sunlight between 6:30 and 7. So then if you expose the baby to this sunlight for about 15 minutes to 30 minutes, it will help to reduce this physiological jaundice quickly. Next comes to pathological jaundice. Now pathological jaundice, I have told you, always it has to be treated. So there are two types of treatment options. So for moderate mild to moderate pathological jaundice, the treatment is called phototherapy. And in severe cases of pathological jaundice, the treatment is exchange transfusion. So we'll see what they are. Now look at this picture. This is phototherapy. So phototherapy is the treatment of moderate pathological jaundice. So here what we do is we close the baby's eyes and genitals, and the baby is exposed to, here it's blue color fluorescent light. So baby is exposed to blue or white color fluorescent light of a given wavelength. So then what happens is, inside the baby's blood, this excess bilirubin, unconjugated bilirubin, is converted into a water soluble substance called lumirubin, and this lumirubin is then excreted in urine. So this entire process occurs without involving the liver. Now the problem is in the baby's liver. So by exposing the baby to this fluorescent light without the help of the liver, this bilirubin is converted into lubirubin, which is then excreted in urine. This is exchange transfusion. This is the treatment of severe pathological jaundice. So here what we do is we remove, the procedure is carried out through the umbilicus. So what we do is we remove the excess bilirubin containing baby's blood out. We remove the blood from the baby's body, and in exchange to that we transfuse the baby with ABO compatible RH negative blood collected from a donor. So this process is called exchange transfusion, and it is the treatment of severe neonatal jaundice, pathological jaundice. Now we'll see neonatal sepsis. What is that? So sepsis is infection. So neonatal sepsis is the infection of the newborn. Mostly it's bacterial infection of blood in the newborn. So neonatal sepsis is of two types. It could be early onset neonatal sepsis, which occurs within the first 3 days after birth, or it could be late onset neonatal sepsis that occurs after the first 3 days of birth. So in early onset neonatal sepsis, the most prominent cause of early onset neonatal sepsis is pneumonia, and in late onset neonatal sepsis, the most adverse complication of late onset neonatal sepsis is the meningitis, right? So that you have to remember. So early onset neonatal sepsis is the neonatal sepsis that develops within the first 72 hours of birth, that is within the first 3 days of birth. And late onset neonatal sepsis is when the neonatal sepsis develops after the first 3 days. So early onset neonatal sepsis mostly causes pneumonia, and late onset neonatal sepsis mostly presents as meningitis. And which one has got the highest mortality? Mortality is the death rate. So the highest risk of death is in early onset neonatal sepsis, and the late onset neonatal sepsis has got a lesser mortality of around 2 to 6%, whereas in early onset neonatal sepsis the mortality is about 50%. So these are the signs and symptoms of neonatal sepsis. So the baby will be irritable. The baby's crying will be unconsolable. Then there will be rapid breathing. There will be skin changes, right? So the temperature will increase. There will be reddening of the skin, right? Then the baby will be floppy, not the normal flexed position. Then the mother will find it difficult to breastfeed the baby, and the temperature will be increased. So if the newborn baby within the first 3 days after birth, if he has got any of these symptoms, they could be due to neonatal sepsis. So then the mother has to carry the baby to the neonatologist for further investigations. So in late onset neonatal sepsis, these are the symptoms. So there will be tachypnea, increased heart rate. There will be tachypnea, that is increased respiratory rate. Then the heart rate will increase. There will be increased pulse rate, therefore, and the mother will find it difficult to feed the baby. Then the baby will show breathing difficulties. Then there will be temperature fluctuations in the baby. Baby will be very irritable and crying, which is unconsolable, and the baby may show features of jaundice also. So these are all features of neonatal sepsis. So this is what you do when there is neonatal sepsis. You do a complete blood count with differential count to see the counts of different types of WBCs, because that will give you an idea as to what type of infection this is, whether it's a bacterial infection or whether it's a viral infection. Along with that, you do a CRP, C-reactive protein. So since this is an acute infection, especially if it's an acute bacterial infection, your CRP will increase. Then you have to start the baby on broad spectrum antibiotics. So while the baby is on broad spectrum antibiotics, you send the blood for culture. So if the culture is positive, you have to continue antibiotics. And at the same time, I have told you, especially after 3 days in late onset neonatal sepsis, it could be meningitis. So sometimes if the baby is very weak and is severely ill, you may have to do a lumbar puncture to see the cause of a meningitis. Then if the blood culture is negative and the baby is well, next you have to you can stop antibiotics, but if the laboratory data are abnormal, although the baby is clinically well, then you'll have to continue the antibiotics, right? So that is how you treat, how you manage your newborn baby with neonatal sepsis. Now we'll see the condition called cleft lip and cleft palate. So if you look at this picture, you can see here there is an abnormality in the lip. So this is what you call cleft lip. And if you look at this, you can see inside the oral cavity there's an abnormality. So this is what you call cleft palate. So we'll see what they are. So first we'll see cleft lip. So here you can see there's a defect in the lip. So it's a congenital defect in the lip. So we'll see what that is. So cleft lip is when the nasomaxillary process fails to fuse between 5th to 8th weeks of gestation. That is usually between 5th to 8th weeks of pregnancy. The nasomaxillary processes have to fuse. Then only the lip will develop normally. So when the nasomaxillary processes fail to fuse during this period, it results in cleft lip. So cleft lip is of several types. So it could be, here you can see it's just a slight defect in the lip. So this is called microform cleft lip. It's just a small defect. Here it's an incomplete cleft lip. Here it's a complete cleft lip, and this is a complete cleft lip together with cleft palate. So these are the different types of cleft lip. So how can you diagnose this? Now during pregnancy, sometimes during 18th to 22nd week of pregnancy, you do an ultrasound scan called a anomaly scan, where all the systems of the baby, system wise, the baby's organs are checked to see whether there is any anomaly. Now usually it is not done to all pregnant mothers, but if there is any history of a previous birth with a congenital defect, then in that mother usually this anomaly scan is done. So when the anomaly scan is done and the baby's systems are examined organ by organ, in that scan you may detect this cleft lip. After birth, it's an obvious defect. So when you're examining the newborn baby, you will see the defect in the baby's lip. So how can you manage that? So management is by surgery. So this surgical correction of cleft lip is called chalioplasty. So by doing a chalioplasty, you can correct the condition. So here you can see this is before the before surgery with the cleft lip defect, and this is after the surgery. This is another example, before and after. So the surgery is called chalioplasty. Now we'll see cleft palate. So cleft palate, the cause is failure of the palatine palates to fuse between 7th to 12th weeks of gestation. So then this is what happens. Now see, this is a normal roof of the mouth. You can see the palatine palates are properly fused. So the hard palate is normal and the soft palate is normal. There is no division or there is no defect. But here you can see the palatine palates are not fused properly. So there is a defect in the center. So this is what you call cleft palate. So cleft palate is again of two types. So it could be, now here you can see there is a defect in the palate which is only in the soft palate area. So this is cleft in the soft palate. But here you can see it's the what you call the two palatine palates have not fused at all. So then the defect is in the soft palate as well as in the hard palate. So this is cleft in the hard and soft palate both. So how can you diagnose this? Once again, during pregnancy, by doing an anomaly scan, you may be able to detect that, because most of the time cleft lip is associated with cleft palate also. And then after birth, that's by physical examination of the newborn baby. So what is the management? Management is always surgery. So the surgical correction of cleft palate is called palatoplasty. So look at this picture. Here you can see the defect. Now this is a patient with cleft, soft and hard palate both. So this is before surgery, and here you can see this is surgical correction. You can see the suture line. So this is palatoplasty after the surgical correction. This is how it looks like, how the palate looks like. So now, what are the complications of cleft lip and cleft palate? Yes, so they find it difficult to suck breast milk. So then they'll have poor nutrition. Then if it is not corrected surgically, they will have, at proper time, they will have speech difficulties. Then this can affect the development of teeth and jaw. And once the baby starts weaning food, by the time, now usually around 6 months, we start weaning the baby with semi-solid food first, and then with solid food. So when this weaning is started, when there's cleft lip or cleft palate, the baby may find it difficult to bite the food. And from this area, infections can enter into the ear. So that's because there is a connection between the middle ear and the nasopharynx, that is called the eustachian tube. So through the eustachian tube, when there is a palatal defect, infections can easily enter into the middle ear and cause middle ear infections. So the babies can have frequent ear infections. So you can see cleft lip and cleft palate have got a lot of complications. Right, so now we'll see some anorectal anomalies or anorectal malformations. So one condition is called cloacal exostrophy. Next we have a condition called imperforate anus and associated genitourinary anomalies. So first we'll see cloacal exostrophy. So this is cloacal exostrophy. So in cloacal exostrophy, what happens is there is malformation. Now if you look at this picture, you can see all the pelvic and abdominal organs, they are not properly formed, and they are not inside the abdominal cavity also, they have come out, right? So malformation of all the abdominal and pelvic organs and exposure of these organs, the intestines and the bladder, to the outside is what we call cloacal exostrophy. So this is how the cloacal exostrophy looks like in a baby. So this is how cloacal exostrophy has to be treated. Now you know, in cloacal exostrophy, all the abdominal and pelvic organs are not properly formed, and also they are outside the body at the time of delivery. So this is what you should do. You will have to do abdominal repair surgeries to replace the organs back in the abdominal cavity. You will have to do bladder surgeries to replace the bladder back in its normal anatomical position. The child may need hip bone adjustments. Then they have problems with placement of their colon and the rectum, anal canal and the anus. So in that case, you may have to do a pull-through surgery to bring the colon back to its normal position and to create an opening for the feces to pass. Then the baby's genital organs may not be properly placed in cloacal exostrophy. So they are all outside the body. So you will have to place them in proper anatomical position by gender assignment surgeries to realign them back in its normal position. Next we'll see the condition called imperforate anus. So sometimes this imperforate anus is this. When, now look at this, now this is the normal anatomy. Now you have the stomach, then you have the small intestine, and then you have the large intestine. So large intestine or the colon. So these are the parts of your colon. Then you will have the rectum, anal canal, and then the anus, which opens to the outside. So in a normal person, there is an anal opening through which the feces comes out. But in imperforate anus, what happens is there is no anal opening for the feces to come out. So it's closed. So the condition is called imperforate anus. So imperforate anus could be, now sometimes it could be simple imperforate anus without any, now in our body, in front of the rectum we have the urinary bladder and the urethra, and in females we also have in females we have the bladder first, then we have the uterus, and then we have the rectum. So sometimes this imperforate anus could be a simple imperforate anus where there is no anal opening, but there is no abnormal connection between the rectum and the organs in front of them, that is the bladder or the uterus and the vagina. But in some cases there may be no anal opening, and at the same time there will be abnormal connections between the rectum, anal canal, rectum and the anal canal with the organs in front, that is with the bladder and with the uterus. So when there are abnormal openings between the rectum and the anal canal with the organs in front, we call them fistulas. These abnormal connections are called fistulas. So sometimes this imperforate anus could be a simple imperforate anus without fistula formation, or sometimes it could be imperforate anus with fistula formation. So these fistulas are always formed with urinary or with genital organs. Therefore, these are called imperforate anus with genitourinary, associated genitourinary fistulas. So this is in a female baby. Now look at this. Now here we have the urinary bladder, this is the uterus and the vagina, and this is the colon, rectum, anal canal and the anus. So this is in a normal person. Now this is in a person with anorectal malformation. So you can see here. Now here the rectum descends along its full length, right? So up to this level, and here you can see there is shortening of the what you call anus. The anus has not extended up to its full. This is confusing. Look at this picture. Here you can see, now this is the uterus, this is the vagina. Now you can see, now this is the anal sphincter. This is the anal sphincter, right? So instead of opening into this anal sphincter, where does the anal canal open into? It opens into the vaginal canal. So this is one abnormality. Now here also the same thing. You can see, instead of opening into the anal opening, it opens into the vaginal canal. So that's in a female baby. Now in a male baby, this is what happens. Now they don't have a uterus, so they have this bladder and then they have the urethra. Now not like in a female baby, in a male baby the urethra is long and it passes through the penis. So what happens is, now this is in a normal person. the anal canal opens into the anus at the anal orifice. But here what happens is the anal canal does not open into the anal orifice because there is no anal opening. So where it opens is to the urethra. So the feces comes out through the urethra. Now in the previous one, in the female baby, now in a male baby, the feces will come out through the urethra, that is through the urethral orifice here. Now in a female baby, what happens is, if the connection, now here you can see the connection is with the here it opens to the vaginal pathway, so vaginal canal. So here in this anomaly, this condition, when the anal canal opens into the vaginal opening, vaginal pathway, then the feces will come out through the vagina. So this is called rectovaginal fistula. But here, or this is a high anomaly, somewhat in an upper level the deformity is. And here what happens is, this opens into the lower part, that is to the urethral opening. So then what happens is, the feces will come out through the urethra. So this is called rectovestibular fistula. So in female babies, feces can, in case of imperforate anus with vestibular form with fistula formation, the feces can come out through the vaginal opening, or it can come out through the urethral opening. And in a male baby, the feces will come out through the urethral opening. So this is in case of imperforate anus with abnormal fistula formation. So in imperforate anus without fistula formation, it's just when the anal opening is not present, and therefore the feces does not come out, but there is no abnormal connection of the anal canal with the organs in front. So these are the signs and symptoms. So when you do the physical examination of the newborn, you will see that there is no anal opening, and even if there is any anal opening, it will be too small, through which you cannot insert a thermometer. Then the baby will not pass meconium, that is, the baby will not pass stools within the first 24 to 48 hours, within the first 2 days. As a result, what happens is, there will be abdominal bloatedness. The abdomen will distend, and they can pass, the stools can come out through the urethra in male babies, or it can come out through the urethra with urine, or through the vaginal opening in female babies. So these are the symptoms of imperforate anus. Now what is the treatment? If it is low anomaly, that is, if it opens to the urethral part and comes out, the stools come out through the urethra, then the treatment is perineal anoplasty. You have to correct it surgically. If it's a high anomaly, what you do is, you create a colostomy, that is, you artificially create an opening on the abdomen. You create an opening in the colon, which is then connected to your outer surface of the abdomen, to the skin, through which the feces can come out. And then you do a pull through surgery. You pull the colon down up to the anal opening, and once the surgery is successful and the anal opening is also created, and then gradually you can remove the artificial tubing, artificial colostomy tube. So then the baby will be able to pass stools in a normal way. So after surgery, always you have to do the dilatation of the newly formed anus for several months until it gains the normal dilatation and a soft scar is formed. So then you can make sure that the tract is properly established, and then you can remove the colostomy, the artificial pathway which you have created to remove the stools. So you can remove the colostomy tube and bag. So these are the nursing considerations in babies with imperforate anus. So suspicion. Nurses will suspect the baby to have imperforate anus when the baby does not pass stools in the first 24 to 48 hours. So preoperatively, correction is always surgical. So before the operation, you'll have to do gastric decompression by nasogastric tube using NG tube. You'll have to decompress. You'd have to decompress the gastric contents, gastric decompression, and then the baby has to be kept nil by mouth. Nothing should be given orally. So IV fluids will have to be given. And then after the surgery, you have to take care of the skin wound. You have to keep the perineal area clean and dry. And also, you have to make sure to prevent contamination. That is, you use when you do the colostomy tube and the fecal bag. The bag will be there. So this can cause contamination. When it spills, it can cause contamination. Or even if you do a pull-through surgery, when the feces dribbles out, it can cause contamination in that surgical area. So you have to take precautions to avoid this contamination. And now this is a procedure which takes several months, sometimes about 1 year to correct. It depends on the baby's weight when you do the surgery. So therefore it's a long-term management. So you have to provide proper advice and support to the family to cope up with the condition. Now we'll see the condition called spina bifida. So spina bifida is a neural tube defect. Now neural tube is the part of the fetus that gives rise or that forms the fetus's central nervous system, that is brain and the spinal cord. So when the neural tube does not develop properly, it can give rise to some abnormalities in the central nervous system formation. So this one such condition is spina bifida. So spina bifida is of 3 types. We have spina bifida, it's of 2 types, spina bifida occulta and we have spina bifida cystica. So spina bifida cystica is of 2 types. One type is called meningocele, the other type is myelomeningocele or meningomyelocele. So if you look at this picture, you will see this is how the spina bifida looks like. So the spine has come out along with its surrounding meninges. So it will look like a lump in the lumbar region of the baby. So this is spina bifida occulta. So occulta is, now it has come out, here you can see the defect, but does not protrude out through the skin. So sometimes the skin may be completely normal without any defect, or sometimes there may be a tough hair or a small skin lump in that area, but no other abnormality. So this condition is called spina bifida occulta. Occulta is when you can't see, right? So that is spina bifida occulta. So this is the least complicated type of spina bifida. Now this is the second type. Here you can see, now surrounding the spinal cord we have meninges. So we have 3 layers of meninges. We have dura mater, arachnoid mater and pia mater, from outside to inside. So this meningocele is a condition where the spinal cord does not come out, but the meninges covering the spinal cord protrudes through the intervertebral discs and comes out. So this condition is what you call meningocele. Now this is the third condition. Third condition, you can see the meninges have come out, and at the same time the spine has also protruded out. So this is the worst or the most dangerous or the most complicated form of spina bifida, and this is called myelomeningocele or meningomyelocele. So these are the types of spina bifida. So spina bifida occulta is the least serious type. It is usually not recognized in most people because there's no deformity seen from outside. So meningocele is when the meninges protrude out but the spine is normal. It does not come out. Then meningomyelocele is when the meninges together with spine has protruded out. So these are the different types of spina bifida, and meningocele and meningomyelocele are the types which are visible from outside. So this is how they will look like. Now, diagnosis. During pregnancy, you may be able to see an abnormal bulging in the lumbar region of the baby, on the lumbar region of the baby when you do an ultrasound scan. So that is during pregnancy. So this is how it looks like. And along with that, you may also see other complications like enlarged head. So that's called hydrocephalus. And after birth, the defect is obvious, right? So this is how it will look like. Apart from that, to differentiate whether it's meningocele or whether it's myelomeningocele, you may also have to do a CT or an MRI of the spine. So in meningocele, it will be only the meninges that have protruded out, and in myelomeningocele, you will see that the spine has also come out along with the meninges. So this is how spina bifida would look like, or these are the clinical manifestations. So this part of the spinal cord controls the urinary bladder and the bowel, that is our colon. Therefore, there will be bladder bowel dysfunction. Then there can be deformities in the foot. There can be hydrocephalus because the CSF drainage does not take place properly. So it leads to enlarged head. Then it can give rise to vertebral column abnormalities, abnormal bending in the vertebral column like kyphosis and scoliosis, the forward bending and the lateral bending of the vertebral column. And then since it's something wrong in the spine, it can obviously give rise to back pain and spasticity of the muscles. So these are the clinical symptoms of spina bifida. So management is always surgical, which is neurosurgical repair of the defect. And also, if there is associated hydrocephalus, it will have to be treated by inserting a VP shunt, ventriculoperitoneal shunt, where the excess CSF in the ventricular system of the brain is brought to the peritoneal cavity. So how can you prevent spina bifida? Now it's a condition that is preventable. So what you should do is you have to take folic acid. Now sometimes you may have heard that pregnant mothers have to take folic acid. So this is the reason. You can prevent these neural tube defects by taking folic acid, because folic acid is required for the normal development of the neural tube. So usually for a normal person, healthy mother, if you take 1 milligram of folic acid per day, you can prevent these neural tube defects in the baby. But if it is a mother who has previously delivered a child with a neural tube defect, sometimes this 1 milligram may not be enough. In that case, she will have to take 5 milligrams of folic acid per day. So when should you start folic acid? Now this neural tube development usually is completed by 8th week of pregnancy. So 8th week is 2 months. So by the time you get to know that you are pregnant, it will be about 1.5 to 2 months. So then if you start folic acid, sometimes it may not be enough to prevent this. By the time by the time you're diagnosed with pregnancy, if you start folic acid, it will not work, because by that time the neural tube is already formed. So when should you start this folic acid? Ideally, you have to start this folic acid at least 3 months before you plan your pregnancy. Then only this folic acid will be very effective in preventing these neural tube defects. Now we are going to look at this condition. So you can see the head is enlarged, and you can see the veins on the dilated veins on the scalp. So the condition is called hydrocephalus. So hydrocephalus is when there's some abnormality in the CSF formation or CSF drainage. So what is this CSF? CSF stands for cerebrospinal fluid. So this is a fluid that is produced in the ventricles of your brain, and which circulates around the brain and the spinal cord. So whenever this CSF formation is excess, or if there is any blockage to this CSF flow, then what happens is your CSF will get accumulated in these spaces. Now usually CSF runs in the in between meninges. So then if the CSF does not drain properly, your CSF will get accumulated in this in between these meningeal layers. And at the same time, if the CSF formation is more, then your ventricles which produce the CSF will get enlarged. So this will make your head to increase in size. But this condition is what you call hydrocephalus. Now if you look at this picture, you will see, now this is the brain of a person with normal CSF formation. So you can see the ventricles are all normal in size, and the CSF flow takes place normally. So the head is normal in size. But here what can you see? You can see the ventricles are enlarged because there's too much of CSF production in these ventricles, and also the CSF does not flow properly. So this makes your head to enlarge because of this increased size of the ventricles. So this is what you call hydrocephalus. And look at this picture. This is how the head enlarges in hydrocephalus. So here are the signs and symptoms of hydrocephalus. So due to increased fluid pressure inside the head, there will be bulging of the frontinalis. Now frontinalis are soft areas on the fetal head where the bones have not yet fused completely. So these areas are soft areas. The bones have not yet fused, so they will bulge out. So then the scalp will become very thin, and you may see the shiny dilated veins on the shiny thin scalp. And the cranial suture lines may separate because in the newborn baby the suture lines are not fused yet, so they can separate. Apart from that, in eyes there will be the setting sun appearance, there will be vomiting and widening of the bridge between the eyes. So these are the features of hydrocephalus. So how can you treat this? So the treatment is, you have to drill the skull and you have to insert a tubing to the ventricle to suck the excess CSF out, and then you have to apply a tubing that will bring down this CSF to the peritoneal cavity. So it is a connection between the ventricle and the peritoneal cavity which we create in order to reduce the excess amount of CSF in hydrocephalus. So this is called VP shunt or ventriculoperitoneal shunt. So this is how you treat hydrocephalus. So now this is the nursing care that is required in hydrocephalus. So you have to make sure the baby is adequately hydrated and the proper nutrition is maintained. So the babies may find it difficult to move, so you have to take care of the body movements in order to prevent bed sores or pressure sores. You have to support the baby's neck and take proper care of the skin to prevent ulceration. And then when the baby is growing bigger, you will have to do neurological assessment and observation of the baby's vital signs, and also you may have to observe the baby for any fits or seizures. Now we'll see congenital heart diseases. So congenital heart diseases are of two types. So in one form of congenital heart, now we know our heart has got two upper chambers and two lower chambers. So upper two chambers are called atria. The lower two chambers are called ventricle. So the right heart, the right atrium receives deoxygenated blood from, that is carbon dioxide containing blood from all parts of the body. Then sends this blood to the right ventricle. From the right ventricle, this blood goes to the lungs. In the lungs, this carbon dioxide is absorbed into the lungs and oxygen is released into this blood. So this blood is then brought back to the left atrium via 4 pulmonary veins. From there, this blood enters into the left ventricle, and from the left ventricle, this blood is distributed throughout the body. So you can see the right side of the heart deals with carbon dioxide containing blood or deoxygenated blood, and the left side of the heart deals with oxygen rich blood or oxygenated blood. So in some congenital malformations of the heart, your oxygenated and deoxygenated blood may mix. So if they mix, what happens is the deoxygenated blood will give rise to increased carbon dioxide in blood. So increased carbon dioxide in blood will give rise to a bluish discoloration of the skin. The condition is called cyanosis, and therefore the types of congenital heart diseases where the oxygenated and the deoxygenated blood mixes are called cyanotic congenital heart diseases. That is because they develop cyanosis or bluish discoloration of the skin. Now the type of heart diseases, congenital heart diseases, where these deoxygenated and oxygenated blood do not mix together are called acyanotic congenital heart diseases. So in acyanotic congenital heart diseases, there is no mixing of oxygenated and deoxygenated blood. So examples for cyanotic congenital heart diseases: the heart diseases where the blood mixes with the deoxygenated and oxygenated blood mixes with each other. Examples are transposition of great vessels, then truncus arteriosus, hyperplastic left heart syndrome, right? Acyanotic congenital heart diseases, examples are atrial septal defect, ventricular septal defect, patent ductus arteriosus, and coarctation of aorta, right? So this is how the congenital heart diseases are classified. So just remember, it's of two types. When blood mixes, you call them cyanotic, or when blood mixes, or when the oxygenation does not take place properly due to poor blood flow from the heart to the lungs, the condition is called cyanotic congenital heart diseases, because these heart diseases will lead to increased carbon dioxide concentration in blood, giving rise to a bluish discoloration to the skin. Now, the type of heart diseases where the blood flow to the lungs is normal, blood flow to the lungs from the heart is normal, and there is no mixing of blood, oxygenated and deoxygenated blood, and therefore there is no rise in the carbon dioxide level in blood, and so no bluish discoloration of the skin, are called acyanotic congenital heart diseases. Now we'll see how these congenital heart diseases are diagnosed. So one thing is history, that is, the mother will say there's poor, there are feeding difficulties, the baby is when the baby is being fed, or when the baby is crying, the baby becomes bluish in color, right? So there are abnormal chest movements in the baby. So then by history you can diagnose the condition. The next thing is examination, that is, by auscultation you may be able to, auscultating the chest using a stethoscope, you may be able to detect some abnormality in the heart sounds. So that is examination findings. Next, by doing certain investigations like chest x-ray will show abnormalities in the heart, abnormalities in the size or the shape of the heart, and then ECG will show abnormalities in the heart rhythm. Then echocardiogram, if you've done, it will show, you can see the structure and the functions of the heart. So in congenital heart diseases, when echocardiogram is done, it will show that there are abnormalities in the heart structure and function. So this is how ECG is done. Now all these, you can see the chest leads are all, the electrodes are all connected to the baby's chest, and then you connect this to the ECG machine and you can take the ECG. So this is how ECG is taken in a newborn baby, and this is how you do the echocardiogram. So here is the probe, you keep the probe on the baby's chest, you move it, and then on the TV screen you can visualize, you can see the structure of the heart, and at the same time you can assess the function of the heart. So that is echocardiogram. Now we'll see some genitourinary malformations in the babies. So one condition is epispedias, the other one is hypospedias. Next you have extrophy of the urinary bladder. So this is epispedias and hypospedias. Now hypospedias is when, now this is in a baby. Now remember, epispedias and hypospedias, these are conditions which you find in male babies. So in male babies there's this penis. So the urethra passes through the penis and opens here. This is where they have the urethral orifice. So if the urethral canal opens on the ventral surface of the penis, below the glans penis, the condition is called hypospedias. And if the urethral opening is located on the dorsal surface of the penis above the glans penis, the condition is called epispedias. So that is how you determine whether it's hypospedias or epispedias. So these are conditions where the location of the urethral opening is abnormal in the male babies. Now we'll see bladder extrophy. So in bladder extrophy, what happens is, the bladder, in a normal person, the bladder is inside the pelvic cavity. But here in bladder extrophy, what happens is, the bladder is not in the pelvic cavity. It has protruded out of the abdomen. So the bladder is outside the body. So this is how the bladder extrophy looks like. So this is bladder extrophy in a female baby, and this is the bladder extrophy in a male baby. So today we have been discussing about some disorders in the newborn babies. So we'll see in the next session. We'll be discussing more about some medical and surgical conditions in the newborn baby. Thank you very much for listening.